Dungca, who will talk on approach to joint pains and joint diseases. Dr. Dungca is a graduate of the College of Medicine, Philippine University of the Philippines. He had his residency training at the Department of Orthopedics, Philippine General, and was the chief resident in his last year of training. Dr. Dungca had his postgraduate fellowship in orthopedic and trauma research at the University of Cincinnati, Cincinnati, Ohio. And his hospital affiliations and current positions are as follows. He's currently the medical director of the Central Luzon Doctors Hospital. He's the head section of orthopedics at the Tarlac Provincial Hospital. And he's the head section of orthopedic in Jackson's Medical Center. May I present to you Dr. Godofredo Dungca.
Good afternoon to all our viewers. It is indeed a great pleasure for me to be here this afternoon for OrthoRoCKs 5. Let me start this afternoon's webinar with a story. There once was a patient who consulted his primary care physician and told the doctor, "Doctor, I'm in pain. My whole body is in pain." And so the astute clinician proceeded to ask him about the character of the pain. So he said, "Where does it hurt? Better yet, point with one finger where it hurts." So the patient pointed to his head and said, "Ouch!" Afterwards, he pointed to his left shoulder, and as soon as he touched it, he said, "Ouch!" Then he pointed to his abdomen, and again, as soon as he touched it, "Ouch!" And then the right knee said, "That hurts." And finally, the left ankle, "Ouch!" And so this left the clinician perplexed. What could possibly be causing all of this pain that the patient is experiencing? It seems to be inconsistent. There's pain in the head, in the abdomen, in the right knee. And then finally, after much thought, the doctor said, "I think I know what's wrong with you. Your index finger is injured. That's why every time you point, it hurts." So with that, we just want to say good afternoon and start this webinar. Seriously, joint pains occur very commonly in the population, and about 22% of adults have been reported to have doctor-related diagnosed arthritis in the United States National Health Interviews Survey in 2016. In that same survey, it was found out that 3 out of 10 adults reported some form of joint pain for the past 30 days. So I guess it's safe to say that in whatever clinical practice or setting you're in, you're bound to encounter patients complaining of one form of joint pain or another. So for this webinar, I would like to share with you some tips and pearls on the approach to joint pains and joint diseases. Let me begin by looking at the typical joint. A joint is where two articulating bones meet, and these are usually covered with hyaline cartilage or the articulating cartilage. The two bones are held together by ligaments and the joint capsule. Within the joint capsule is a synovial cavity which is lined by the synovium. Around the joints are the tendons that attach to the muscles and the bone. In between the muscle tendons and the joints are structures called the bursa, which allow these tendons to glide smoothly over the joint. The junction between ligamentous structures and the bone is an area called the enthesis. Now, looking at all these structures, all of them can be sources of pain, except for the articular cartilage. The articular cartilage by nature is a neural, meaning to say that it does not have any joint nerve endings. That's why it does not transmit any pain signal. Now, knowing that these structures around in and around the joint can be a source of pain, there's also such a thing called referred pain. And this pain that is perceived as coming from the joint, although they may actually originate from another site or source. This is because the sensory fibers shared by the joint with other structures may actually be transmitting the pain signal. Now, in any patient coming to you with a complaint of joint pain, one has to determine where the pain is coming from and what is causing the pain. Is it referred pain or is it pain coming from within the joint? Referred pain is coming from neural structures and is often characterized as either burning, stabbing, or a shooting kind of pain. It is also sometimes described as pins and needle sensation, and that this may be associated with numbness or at times an electric shock-like sensation. The thing about joint diseases is that there is usually associated pain on motion, or there is some limitation of joint motion. The absence of pain on passive motion of the joint usually points to a referred kind of pain and a probable pathology which is not near the joint. Now, having determined that the pain is most probably being caused by structures within or adjacent to the joint, the next question we ask is, what pathologic process is causing the joint pain? There are generally 5 pathophysiologic types of joint diseases. You have your synovitis, your enthesopathy, your crystal deposition, your infection, and your structural or mechanical derangement. Synovitis refers to the proliferation of the synovium, which is the lining of the joint, and is clinically manifested by warmth, tenderness, and a boggy consistency of the soft tissue around the involved joint. Enthesitis refers to the inflammation of the transitional zone where the collagenous structures such as tendons and ligaments are interwoven into the joint. In this particular case, you can see that the heel on the right is inflamed, and this is most probably caused by inflammation in the enthesis of the Achilles tendon as it attaches to the calcaneus. Crystal deposition occurs when excess crystals deposit on the hyaline cartilage within the synovium or in any periarticular structure and causes inflammation of the joint. This can further lead to destruction of the joint in some cases. Joint infections usually arise from blood-borne organisms and may be a part of systemic infection. The synovium is usually the seat of acute or chronic infections, which may be bacterial, fungal, or viral in origin. Structural mechanical derangement refers to abnormalities in the alignment of the joint surface and can cause damage and degeneration of the articular cartilage, which leads to arthritis. As you can see in this example, there is bowing of the left leg, which causes the mechanical axis to fall on the medial side of the knee rather than distributing the weight equally on both the medial and the lateral side. This causes destruction of the cartilage on the medial aspect of the knee as seen on the X-ray. Now, after having reviewed the pathophysiologic cause of joint diseases are broadly categorized into 3 classes, namely the inflammatory arthritis, the non-inflammatory arthritis, as well as arthralgia. When we say an inflammatory arthritis, the pain is stemming from the joint and is characterized by inflammation, which affects the joint structures such as the synovium, the synovial cavity, and the enthesis. Non-inflammatory arthritis are joint diseases resulting primarily from alterations in the structure or mechanics of the joint. This can result either because of cartilage or meniscal damage, with concomitant alteration in the structure of the subchondral bone or alterations in joint anatomy caused by congenital, developmental, metabolic, or past inflammatory diseases. Arthralgia is characterized by joint tenderness, but abnormalities of the joint cannot be identified definitely. Such patients may have a syndrome of altered pain sensation, such as fibromyalgia, or an early rheumatic syndrome whose clinical signs are not yet apparent or are too subtle for detection. Although it would be neat and quite convenient to categorize joint diseases into these three types, they may actually occur simultaneously in the same joint. Inflammatory joint disorders often lead to structural derangement of the joints, and similarly, structural joint problems such as traumatic arthritis or osteoarthritis often have an associated, although minor, inflammatory component. Now, when taking the history of the patient, there are specific features which are associated with joint diseases. And these are things that we should ask and look for when we do our patient evaluation. These in particular are onset, duration, and temporal pattern of the arthritis, the number of involved joints, the symmetry of joint involvement, its distribution. We want to find out if there are distinctive types of musculoskeletal involvement as well as extra-articular manifestations of the joint disease. When we talk about the onset of joint pain, we talk about either abrupt onset or insidious onset. With an abrupt onset, the joint symptoms develop over minutes to hours, and this may occur in the setting of trauma, crystalline synovitis, or infection. With an insidious pattern, the symptoms develop over weeks to months, and these are typical in most forms of rheumatoid arthritis and osteoarthritis. With respect to duration, symptoms are either acute or chronic, with acute symptoms being defined as those that have been present for less than 6 weeks, and chronic symptoms defined as those that have lasted for 6 weeks or longer. The temporal pattern of joint involvement are migratory, additive or simultaneous, and intermittent. With the migratory pattern, inflammation persists for only a few days in each joint, for example, in acute rheumatic fever or disseminated gonococcal infections, whereas with an additive or simultaneous pattern, inflammation persists in involved joints as new ones become affected. With an intermittent pattern, episodic involvement occurs with intervening period of free joint symptoms, as in gout or pseudogout or Lyme arthritis. When referring to the number of joints involved, we say monoarthritis when there's only one joint that is involved. Oligoarthritis involves 2 to 4 joints, whereas 5 or more joints is referred to as polyarthritis. Symmetric arthritis is characterized by involvement of the same joint on each side of the body. This symmetry is typical of rheumatoid arthritis and systemic lupus erythematosus. Symmetric arthritis is characterized by involvement of different joints on 2 sides, and this is typical of psoriatic arthritis and reactive arthritis. With regards to distribution, the distal interphalangeal joint of the fingers are usually involved in psoriatic arthritis, gout, or osteoarthritis, but are usually spared in RA. Joints of the lumbar spine are typically involved in ankylosing spondylitis, but are also spared in rheumatoid arthritis. Different diseases exhibit distinctive types of musculoskeletal involvement. Spondyloarthropathy involves the enthesis, and this sometimes may lead to heel pain because of inflammation in the insertion of the Achilles tendon or plantar fascia, dactylitis or sausage digits, tendinitis, and back pain. Gout, which involves tendon sheets and bursa, also results in superficial inflammation. Now, there may be extra-articular manifestations of joint diseases. Constitutional symptoms suggest an underlying systemic disorder and are not expected in patients with degenerative joint disease. Okay? This may include fatigue, malaise, and weight loss. Skin lesions may be present, like for example, the characteristic malar rash of SLE or the skin plaques of psoriasis. Scleritis is often associated with spondyloarthropathy. After having gone through the patient's history and characterizing the joint involvement, we now go to the examination of the joint. When you examine the patient's joint, you want to inspect, palpate the joint, as well as examine the range of motion. When you inspect the joint, you look for deformities, like in enlargement of the joint. You want to look for the alignment of the joint and see if there is anything that deviates from the usual alignment, especially in the lower extremity. You often do this with a patient standing or weight bearing. You also look for obvious signs of swelling or synovitis, as well as signs of erythema. When you get the chance to palpate, you also look for swelling and synovitis. Synovitis is often described as a boggy or doughy feeling of the soft tissue around the joint. You also want to see if there is evidence of effusion, and usually this can be detected with what we call ballotment, or when you try to press one side of the joint and feel the bulging of the fluid in the other side. Of course, you can see erythema and warmth. You can usually compare one side to the other, or the same extremity, one side distant and one near the joint. Warmth usually would indicate the presence of inflammation. Of course, as you palpate, you want to see if there are areas of point tenderness that could point to specific pathology. The examination of the range of motion is important in trying to determine joint pathology. You want to examine for active and passive range of motion. A joint that is painful throughout the range of motion indicates acute inflammation. A joint that is limited in motion may point to a possible structural defect. Again, if there is no pain on passive range of motion, but the patient complains of joint pain, then probably you have a referred type of pain with the pathology coming from elsewhere aside from the joint. When you do the range of motion, you can also try to feel for crepitus or abnormal sensation during the range of motion. Again, limitation of motion may point to a structural defect. Now, after having done your examination and you're still unsure of whether there is indeed an inflammatory or non-inflammatory type of joint disease, you may want to order for screening test. And the screening tests for all inflammatory arthritis are as follows. In the setting of joint pain and equivocal joint examination findings, an elevated DSR supports the presence of an inflammatory arthritis. The CRP level is a non-specific measure of inflammation and is obtained as an alternative to obtaining the ESR. However, in contrast to the ESR, the CRP level can be measured on frozen serum and is not influenced by the presence of anemia or hyperglobulinemia. It also rises more rapidly in response to inflammation, but may require more time for the lab results to be available. For example, it takes 24 hours for the CRP results to come out, in contrast to 1 hour for the ESR. Now, a rheumatoid factor test should be obtained when rheumatoid arthritis is considered at least moderately possible. Results may be positive in as many as 20% of healthy persons and in persons with other rheumatic diseases such as SLE. The CCP or cyclic citrulated peptide antibody has a higher specificity than the rheumatoid factor test but lower sensitivity. It is particularly useful in evaluation of patients with joint pain in whom rheumatoid factor titers are low and findings on joint examination are not definitive for synovitis. The anti-nuclear antibody tests are commonly obtained in patients with arthralgias or arthritis as a screening test for SLE or other connective tissue disorder. More than 95% of patients with SLE have positive anti-nuclear antibody tests. Thus, a negative NA result is a strong indicator that SLE is not present. However, a positive ANA result lacks specificity and may occur in persons with other connective tissue diseases or certain medical illness, as well in 5 to 10% of otherwise healthy individuals. After having done your laboratory examinations, the next question is, when do we request for X-rays? After all, radiographs of joints are very cost effective and are the cheapest form of imaging studies for the joints. We usually request for radiography if we are suspecting joint structural or mechanical problems, such as in osteoarthritis. We also want to order this if we are trying to monitor the progression of inflammatory diseases like rheumatoid arthritis, as this can cause joint destruction. This gives us a good picture of how the disease is progressing. We also want to request for X-rays if we cannot explain the tenderness elicited during the physical examination. This condition, called arthralgia, often points to pathology which may not immediately be obvious. In this case, for example, we have an undisplaced intra-articular fracture of the distal radius, which is not really evident on physical examination except for tenderness and with minimal swelling. But with the X-ray, we see that there is that fracture on the X-ray. When you have unexplained constitutional signs and symptoms such as sudden weight loss or body malaise or weakness, coupled with joint pain, it might be good to have an X-ray of the joint involved. As in this case, we see that there are lytic lesions just above the hip joint, which may point to a possible metastatic condition. Ultrasonography is another imaging technique that can point to the possible origin of the joint pathology. This is usually done by trained musculoskeletal radiographers, and in the setting wherein you have possible joint infusion, this is useful to localizing where the needle will be located to aspirate the fluid, as well as to infiltrate the proper structure when you want to inject corticosteroids. Now, joint aspiration is a very useful adjunct when the joint is obviously swollen and has joint effusion. This can give you a good idea of what the nature of the fluid is. Just as a caveat, if you're thinking of a possible infectious process prior to aspiration, it might be good to refer to your friendly orthopod before you do the aspiration, as the orthopod may be in a better position to locate where the needle is stuck, as well as to proceed to drainage if there is indeed infectious or septic arthritis. Now, the joint fluid may be sent for joint fluid analysis, and what you want to look for is the volume of the aspirated fluid, its clarity or color, the viscosity, the amount of white blood cells, as well as the percentage of foreign morphonuclear cells present in the aspirate. Normally, a joint would contain less than 3.5 milliliters of joint fluid, with the fluid being transparent or clear, with high viscosity, and a very low WBC count, less than 200 per cubic millimeter. A non-inflammatory aspirate, often, although more than 3.5 milliliters, is still transparent, may be yellow in color, still with high viscosity, but still a relatively low WBC count, below 2,000, with less than 25% polymorphonuclear cells. An inflammatory aspirate, on the other hand, while still may be yellow to clear, may be slightly opaque, the viscosity is low with a slightly elevated WBC. The acceptable range is 2,000 to 100,000, but usually this is below 50,000 WBC per cubic millimeter. And the polymorphonuclear cells are less than 50. A definitely septic aspirate will be opaque, yellow-green in color, and the viscosity variable. The WBC count usually is about 50,000, and more often than not exceeding 100,000 with more than 75% polymorphonuclear cells. A hemorrhagic aspirate usually is very bloody, and you cannot mistake it for any other kind of aspirate. It's red, and the WBC cell count is still low. If we go back to the previous slide, you can see on the left, you can have an inflammatory type of aspirate, which is yellowish in color, and slightly opaque. On the right, you have a very obviously septic aspirate, which is almost greenish brown in color, and very creamy in consistency. Now, the aspirate may also be sent for polarizing microscopy study, compensated polarizing microscopy, if you're considering a possible crystalline deposition disease. Okay? In the setting of possible inflammatory disease, but with equivocal aspirate analysis, the compensated polarizing microscopy will show if you have gouty crystals. In this case, you have your negative bifringent needle-like crystals, in contrast to calcium pyrophosphate, wherein you have the crystals in rhomboid shape, not and slightly positive bifringence. Okay, so again, you will see that in gout you have your needle-like crystals, whereas in pseudogout they are rhomboid in shape. Now, after having gone through your history, your physical examination, as well as your diagnostic examinations, it would be good if at the end of all of this you can classify your joint diseases into one of three, namely inflammatory arthritis, non-inflammatory arthritis, or arthralgia. Inflammatory arthritis, again, refers to joint disease wherein you have inflammation of the structures in and around your joints. Whereas non-inflammatory arthritis usually occurs to structural or mechanical derangement within the joint. Again, arthralgia refers to joint tenderness which cannot be explained immediately by your history or physical exam findings. Now, the goal of treatment in any patient with joint pain is relief of pain, the restoration of joint mobility, and the preservation of joint structure. For inflammatory arthritis, this will involve some rest, your prescription of anti-inflammatory medications or your regimens. Sometimes this involves intra-articular steroid injection. And if the swelling has subsided, your physical therapy so as to preserve your joint function. And for chronic cases wherein there might be the possibility of joint damage, a referral to your rheumatologist will allow the specialist to prescribe your disease-modifying drugs. Now, for your non-inflammatory arthritis, okay, of course, you have your pain medications, mainly your anti-inflammatories. Okay, sometimes you might have to give opioids if the patient cannot be given this or there are contraindications. You want to correct the structural or associated mechanical defect so as to preserve or restore joint function. You may use joint aids such as walkers and the like so as to offload the joint in weight-bearing joints. In these cases, for non-inflammatory structures with mechanical defects, it might be best to consult your friendly orthopedic surgeon who may be in a better position to address these problems. Now, for arthralgias, you might want to broaden the search for your pathology, and this might include multidisciplinary referrals, especially if there are warning signs or red flags. And what are these? You have your high-grade fever, your unexplained weight loss, and severe constitutional signs and symptoms. At times, in the setting of joint pain with erythema, swelling, as well as severe pain and high-grade fever, you might want to hospitalize the patient because you might be dealing with a possible septic arthritis. Again, the goal for treatment is to have a pain-free functional joint so that the patient may be able to move freely. So, in summary, joint pains and joint diseases are commonly seen in any medical practice. A good focused joint history helps narrow down the differential diagnosis, helping us come out with at least three broad categories for joint pain. The good management of joint pain and or the disease emanates from a good and accurate diagnosis. Thank you very much for your kind attention, and these are my references for this talk.
Dr. Dungca, may I ask you, in your first beginning of your talk, when you had that story about your patient, would it be better if you ask your patient to move the different joints you enumerated in order to better zero in on the problem? Or is it, in other words, is it safe to say that musculoskeletal problems usually have pain on movement?
I agree with you, sir, that most musculoskeletal problems elicit pain on movement. Okay, that's why it's important that you do your examination of the joint, both passive and active range of motion. Okay, uh, again, pain that is perceived to be in the joint, but is not perceived during passive range of motion, most probably is the referred type of pain.
Another question. In your CSF analysis, do you routinely also order for blood sugar and total protein, or you just rely on the result of the qualitative examination of your synovial fluid?
For the most common cases, the routine synovial fluid analysis is enough. Okay, although we may request for the sugar and protein, by experience, that not very many laboratories in our country are able to do that. So, for the more common forms of arthritis, I would just rely on the common joint aspirate analysis.
And about the CRP, what would you prefer? Is it the qualitative or the quantitative CRP?
The quantitative CRP would give us titers that would uh, tell us if we are dealing with more specific conditions. So if uh, the laboratory is able to give you the exact titers, this may be more useful in narrowing down your diagnosis.
Uh, Lastly, with regards to septic arthritis, is there a role for non-surgical treatment of septic arthritis?
For septic arthritis, uh, it usually is better to actually drain the joint. Although there have been in the past ways of draining the joint wherein you infuse fluid in an inlet and then drain it with another needle stick as an outlet and let this continuously flow. Um, in my experience, it's still better to open up the joint and really clean it. So if you're entertaining a septic arthritis, I think an orthopedic surgeon is in a better position to do so because we can actually do surgical drainage and debridement of the joint.
You may field in your questions. Okay, if there are none, I would like to thank everybody for following the first of the series of webinar for this morning. Thank you. Thank
Thank
you,
you.
Dr. Dunca.
Thank you, sir.